morning, everyone on the west side of the country, and good afternoon to our friends joining us from the East Coast. Welcome so much to our third annual EmPOWER M.E. Roundtable. This year, we're talking about the real hot topic, elevating your voice in research. And we'll be hearing from some really great speakers today about how research and the patient community can really be partners in creating answers for long-term health. Today, we have a keynote address from Representative BEYER, but before we get started, I'd just like to share a couple elements and housekeeping about our system today. We are on the Zoom webinar platform. Unfortunately, we will not have the opportunity for Q&A in this event, but we invite you to join our office hour panels tomorrow, where you'll have direct access to our speakers to be able to ask questions in a confidential setting. So if you would like to share your thoughts or some insights, you can use the chat function to continue the conversation in the text-based space. And if you'd also like to use the Q&A, we can do our best to get to those questions during the office hours tomorrow, but they will not be addressed in the panel today. Last but not least, if you would like the transcription function to use the live closed captioning, if that's a service that helps you access our conversation today, please make sure to click the CC button. It's a gray button with the two CC letters on it that says closed captioning at the bottom of your Zoom window. So without further ado, thank you so much again for joining us, and to welcome you and get us kicked off, please have a warm welcome for Ovid Amate, the President and CEO of Solve ME-CFS Initiative.
Thank you very much, Emily, and welcome everyone. It is truly my honor to introduce Congressman Don BEYER today. Congressman BEYER is serving his fourth term as the U.S. representative from Virginia's 8th District. And Representative BEYER serves on the House Committee on Ways and Means, which has partial jurisdiction over healthcare, and he's the chairman of the Joint Economic Committee. He also serves as on the House Committee on Science, Space, and Technology, where he chairs the Space Subcommittee. And he is also the co-chair of the New Democrat Coalition's Climate Change Task Force, and I wanted to note that in particular as we mark Earth Day today. But related to our discussion today about research and participation of patients in research, he previously led the successful efforts to reauthorize and fund the Patient-Centered Outcomes Research Institute, also known as PCORI. And he spearheaded the House push to fund the Agency for Healthcare Research and Quality, also known as AHRQ. Representative BEYER was the Lieutenant Governor of Virginia from 1990 to 1998, where he's very well known for his signature work as the champion for Virginians with disabilities. So clearly topics that are related to medical research and the centrality of patients' voice are dear to his heart. However, most recently, Congressman BEYER made headlines for yesterday's announcement of the COVID-19 Long Hauler Act. This is a bipartisan bill that he co-sponsored with Representative Bergman from Michigan. And this act, the COVID-19 Long Hauler Act, is calling for funding for research, education, and infrastructure that are really absolutely critical for long COVID and also for our understanding of post-viral illnesses such as ME-CFS. Representative BEYER, thank you for your leadership on all these really important issues, and we welcome you to our third annual EmPOWER M.E. Roundtable. Thank you for joining us here today.
Thank you, Ovid, very much. The only other Ovid I ever knew wrote a bunch of poetry in Latin, so it's fun to meet a new one, and especially in your leadership role at EmPOWER M.E. And I'm really honored to give opening remarks today. You know, I am new to the myalgic encephalomyelitis phrase, but I have, the few times in my life I've been so exhausted that I had to go to bed for 2 or 3 days, I have to confess, nothing frightened me more than the idea of getting ME. So thank you for all of your leadership, trying to discover the research and the methodologies to help people avoid this and overcome it. I was asked to speak today about one of the bills I'm about to introduce, but also to touch on diversity and inclusion in research. And I have to say that inclusion in research has always been a really strong priority for me, especially patient inclusion. I was honored to lead the reauthorization of the PCORI legislation, Patient-Centered Outcome Research Institute, last Congress. And it was really enlightening to visit a number of the PCORI research projects around the country and just see how much progress they're making by listening to the people who are affected by the illnesses or the syndromes that they had. And we need a federal advocate to improve our experience in this confusing, complicated health system. So my latest bill addresses inclusion also, but for a particular and developing community, COVID long haulers. So with Congressman Jack Bergman, who is a retired Marine Lieutenant General and a Republican from Michigan, we're introducing this together probably next week. We think that COVID, when we think of COVID-19, most Americans are focused on how many people are in the hospital, how many people died, and the very reasons we all need to be vaccinated. But what we rarely talk about are the symptoms that don't go away immediately after the acute infection. These folks they self-identify as long haulers, or what we now call long COVID, because how long it takes to recover is different for everybody. Many people will feel better in a few days or a few weeks, full recovery within 12 weeks, but for some people, symptoms can last longer. And weirdly, the chances of having these long-term symptoms doesn't seem to be linked to how sick you felt when you had the coronavirus. People who have mild symptoms at first can still have really long-term problems. And conversely, long COVID can often be much worse than their initial bouts with the infection, and with a stubborn and complex array of symptoms. One example close to home is my dear friend, Senator Tim Kaine, who was governor of Virginia and now a senator from Virginia, who didn't even know that he had COVID until he took one of the antibody tests, but has said that for the last year, he has felt terrible. So didn't know he was sick, but definitely knew that he had it after the fact. A study analyzed that medical records in California found that nearly a third of the people struggling with long COVID symptoms, like shortness of breath or cough or abdominal pain, didn't have any signs of illness in the first 10 days after they tested positive for the coronavirus. And surveys by patient-led groups found that many COVID survivors with long-term symptoms were never hospitalized. Now, for most improve over time, but there's a big wide variation. So some people after 2 months are 95% recovered. Some people after 9 months are only 10% recovered. There was an Italian study that showed that 87% of hospitalized patients still had symptoms after 2 months. So, and then the team from the Centers for Disease Control and Prevention found that a third of 270 non-hospitalized patients still hadn't returned to their usual state of health after 2 weeks, as opposed to the flu, where 90% are feeling fine after 2 weeks. So the overarching takeaway, put all the statistics aside, is that millions of Americans who have had COVID are still suffering from COVID. And who those are, why it's still happening, that's what we have to figure out. How do we treat it? And how do we identify it? So I'm really proud that in the latest COVID package, we allocated over $1 billion in research to NIH to study long COVID specifically. But what's still missing is the practical application of how we respond to it and what we can do to this huge community of people who still suffer from it. And this is a cohort that the medical community hasn't really figured out how to handle. They've been so focused appropriately on first keeping people alive in the hospital and now getting the vaccines come out. So this is where our bill comes into play. We know that much of the information, the important information, comes from patient forums, from limited serious studies, and siloed work by medical practitioners. So the cardiologists are going to think about COVID in the heart, and the neurologists are going to track impacts on the brain, but we're missing the complete picture. And when you think long COVID, think every system in your body. So this is that rare moment in time when we are evolving in real time, today, this afternoon with EmPOWER M.E, to respond to the pandemic and the response, to address the silent wave of long haulers. So the bill does a couple of cool things. It synthesizes our siloed data. It creates these great databases. What are the symptoms? What treatments work? One of the really wonderful things is we're hearing from a lot of people, including, I mentioned Senator Tim Kaine, that when they get the vaccine, their symptoms often go away, which would be very cool if that bears out over time. The bill also attempts to improving long COVID care efficacy, delivery, disparities, we shouldn't be surprised that the same kind of disparities that we see in vaccine delivery or in early identification of COVID is also going to affect the long COVID sufferers. And lastly, most importantly, we need to educate all of our citizens and our clinicians about long COVID. So often with new illnesses, it takes quite a bit of time for even the scientific community to say, oh, that's real, and I need to be looking for this right away. We need to be taken really seriously by the medical community. But that's not the only way that I think about diversity and inclusion. I'm on the Science and Technology Committee, and we're constantly thinking about how do we make sure that the nation's research enterprise is addressing inclusion and diversity. And this is on the science side. How do we get more women, diverse people into math, science, biology, medicine, physiology, all those important things? And then how do we make sure that we're serving those people who are often the ones most neglected? By the way, Ovid mentioned that I chair the Joint Economic Committee. We have the exact same challenge in the economics field, is how do we make sure that all of our economists aren't old white men like me, and that we have this wonderful exploding group of women economists interested in how the economy affects women, especially. And early data suggests, of course, that people of color are really bearing the greatest burden from the changes that COVID-19 has brought to society. They die much more often or are hospitalized much more often, but they're also, it's their small businesses, the smaller research institutions like at the historically Black colleges and universities and the like, that don't have the ability to do alternative instruction, alternative lab experiences. Female research faculty work from home and teach virtually, while remaining primary caregivers for the kids are facing the same unprecedented pressures. I mean, virtually everything we see is that this COVID crisis has hit women and minorities much harder than the rest of our population. So all we can do together is just make sure that we're constantly aware that every piece of the research equation needs to include diversity and inclusion. So I'm very thrilled that there is an EmPOWER M.E, and I thank you for all the work. And Jack Bergman and I, and hopefully a large group of Democrats and Republicans, will come together to make sure that we are putting the money on the table and in the hands of the researchers to really help the folks suffering from long COVID. And I apologize for the whining dog who's going to be really unhappy when we have to go back to work in person. So thank you. Ovid, I yield back to you and looking forward to our conversation.
Thank you very much, Congressman. And Emily, I think we're gonna go ahead with the rest of the program.
Absolutely. Thank you so much, Congressman BEYER and Ovid for your time today. And never apologize in this world for having an extra puppy or kitty arrive on the screen. We find them the most welcome Zoom friends for all of these events. So thank you so much for sharing both your pet and your thoughts with us. We were so thrilled to hear, especially your insights on diversity and the amazing work that has been done both in Virginia and on Capitol Hill to expand the inclusion of diverse patient populations in the research. So thank you so much, sir, for your time, for your leadership, for all of this amazing collaboration that's happening between members of Congress on both sides of the aisle. And it wouldn't have happened without you. So thank you, sir, for your time today and your leadership. And we look forward to continuing the conversation soon. So without further ado, it's my absolute pleasure to introduce Dr. Sadie Whitaker, Solve ME's Chief Scientific Officer, who will be talking and leading our discussion today about patient inclusion in research.
Thanks, Emily, and thanks, Representative BEYER. You are actually the first member of Congress that I've met, albeit virtually. I have a very weak understanding of American politics that's mostly centered around what I know from Hamilton, the musical. So I'm thrilled to be able to meet you. And although I know very little, I do know that people don't often work across the aisle. So I'm thrilled that you've been able to do that on behalf of long haulers. So as Emily said, I'm the Chief Scientific Officer at Solve, and I'm really excited to be here today, mainly because I feel passionately about health empowerment. Nobody knows more about what the symptoms of a chronic illness than the person who's actually going through it. And it's been a passion of mine to bring that expertise into research. Last year, we launched U+Me, you see the logo there on the slide, which is a registry and biobank set up with the goal of better understanding ME/CFS and long COVID and what causes susceptibility or resilience to chronic illness. So right when we were beginning to build the registry, we established some core values that would govern how we would operate. And these were centered around the principles of patient-led research, but also a sense of community and equality. So everybody who was part of the registry, whether they were individuals with the disease, caregivers, researchers, providers, everybody was an equal member. There was no hierarchies. Everybody had a different but equally valid expertise. So we took that expertise from the community. We spoke with people who were living with chronic disease to co-create the registry, how we were going to collect the data, what the mobile tracking app was going to look like, and really co-created that with the people who were going to be using it. And we still actively seek feedback. We're enhancing the infrastructure on an ongoing basis. Anybody who's part of the registry gets the chance to share research questions that they're interested in. So this is not, like I said, it's not a hierarchy where individuals contribute their data and then researchers choose what to study. This is really anybody who's part of it can suggest a research question, and those research questions can be upvoted, considered by researchers for study, and the data that's generated is fed back to the participants. So it's a nice feedback loop. I think because of that approach, I think that's why we've been so successful so far. So we have about 3,200 individuals sharing their data, and we have really strong engagement with our symptom tracking app, which we're thrilled about. And if you haven't had a chance to check that out, please go to our website. It's youandmeregistry.org.com, I think, sorry. So transitioning a little bit to COVID and the pandemic, you know, the pandemic's resulted in this groundswell of patient-led research. And to me, I find it very satisfying. The old ways of doing things are not how we should do things, you know, data silos where people aren't sharing data, or studies are shared behind a firewall in a journal that people can't access. What I love about what's happened with long COVID is really this groundswell of grassroots data collection. People are sharing their information, and that information is being organized and published on, you know, Google Sheets. Anybody can look at it, and it's really serving to accelerate what we know about long COVID in the hopes of getting to solutions more quickly. So I'm delighted today to introduce three individuals who are at the forefront of patient-led research. The first is Shamir Smith. So Shamir is a middle school teacher, a writer and a thought leader. She has recently appeared on MSNBC Live with Craig Melvin, in the Washington Post, in Medium, and on PBS NewsHour. She's been consistently coined as a passionate patient-led advocate after using insistent communication to attract the attention of local politicians, doctors, and hospital administration to receive life-saving care as she battled COVID-19. Since June of 2020, Shamir has used her social media platforms and grassroots engagement in COVID-19 support groups, as well as a strong media presence, to raise awareness of how important it is to include Black voices in conversations in the prevention, treatment, and research of long COVID in urban communities. So Shamir, thrilled to have you join us today, and I'll hand it over to you to talk through a few slides.
Thank you so much. I want to first begin by creating a space of love, care, and gratitude for the other Black women I've met and absolutely adore who have long COVID and ME. I want to shout out Nisha McCrae, Kimmy Campbell, Candace Taylor, Cynthia Adenig, Wilhelmina Jenkins, Ashanti Daniels, Dr. Margot Gage, Lisa Fisher, Marcella Jackson, Tracy Jean Thompson, Lotus Lover 3000 on Twitter, Ariana Edwards, and many, many more. I honor today the spirit of my grandmother. Her name was Frances Eloise Noble Smith, who died before I was born. She died of pancreatic cancer. She didn't live long enough to have her condition studied or researched. I'm doing this in part for her. Thank you so much to Solve ME for offering me this opportunity to speak today. The newly announced Long Hauler Act is a hard act to follow, but I'm honored to even try. Shout out to Representatives Bergman and BEYER for their diligence and commitment to long COVID patients. I have a secret to tell you as I start speaking. How I measure my life may not be how you measure yours. As a Black woman, I live my life by measuring first. I have no other choice. Growing up in the hood of Southeast DC, I was socialized to believe that by being the first of any, I would automatically obtain recognition and rewards. People would pay attention if I was the first and if I was Black. Now, don't get me wrong, there are benefits of being first. I was the first girl to ask for a football in a gym class while living for a short while in West Virginia. In high school, I was the first female president of an urban community group. I was directed to apply for scholarships and grants that identified me as the first Black girl in my household to attend college. I know some of the glory of being first, but there are also many pains involved in being the first of many. And I can assure you that over the last year, being first or one of the first may have landed me recognition, but it certainly hasn't been all that rewarding. I was the first person I knew to contract COVID. I was the first person I knew whose body didn't clear COVID in 2 weeks. I know that being Black and first helps corporations and organizations sell dreams of diversity, inclusion, and culture. It adds clicks and views. It means acceptance. It makes people's ears prick up with possibility. While being Black and first often represents some strange sort of accomplishment, it hides the pain of having to wear the label for all the wrong reasons. Being Black and first sometimes is lonely, it's isolating, it's humiliating, embarrassing, and sometimes it's frustrating at best. While there are cheers about my long COVID advocacy and an admonishment to do more, being Black and first often means that I am the Black, first, and only woman to do a thing or another. I can tell you that it's hard to be first. I'm tired of being first. I eagerly await for the day when I can stop being first to step into the pool of many. I shouldn't have been the first Black woman to publicly challenge research companies to incorporate Black people in urban communities in their studies. I shouldn't be the first Black woman in long COVID organizations. I shouldn't even be the first Black woman along with 3 other beautiful Black women to be featured in a Time magazine health story linking long COVID with ME, but I am. And that herein lies the tragedy of being first. Being Black and first still is a big deal because we've made it one. We consistently create research organizations and opportunities with Black people as an afterthought in the planning process. And then we wait for the aftershock as people complain, only to then reward Black people with the token of being Black and first. Most people don't know that there is pressure behind being Black and first. Specifically, Black women who are first don't often get to relish in being parts of movements because we are laser focused on creating lanes, spaces, and environments that are conducive for other Black people to reside in. One thing I noted about who was the first to speak about long COVID in the media is that they were mostly white women. Who were the first to galvanize support groups and research studies? White women. Who first volunteered to interview me and include me in long COVID spaces? White women. I don't blame anyone for these facts, but I don't imagine oftentimes that white people have to wonder much about being the first of many things. They are the many. There's a privilege in being part of the many. And if I hadn't identified that anywhere else over the last year, I see it clearly as I explore long COVID research opportunities and wonder why I, as a Black woman with a few firsts under my belt, have to beg to be included. I know what you're thinking, and I agree. Well, I don't hear or see Black people knocking down doors to be first to act as willing participants in medical and scientific research. And there are tons of reasons why. I don't need to spend much time reminding you that there is a contentious, frightening, and heartbreaking relationship between Black people, science, and medicine. Often we have been excluded from science or given minimal access to it to satisfy some narrative, only to be abandoned by it when our services have already been rendered. The pain of being Black and first has caused me to challenge large medical organizations who have the money and the power to change the standard and integrity of how we engage Black people in long COVID research, because I'm tired of being the first. I no longer want to carry this like a badge of honor. We can't continue to perpetuate the narrative that we understand that there are disparities and inequities in healthcare research and treatment if we are not creating innovative standards that allow many Black people to participate. Understanding this narrative also means that we hang up the red tape requiring that patients with long COVID have positive PCR tests and copious medical notes, both of which have been reported as almost non-existent for many early and first waivers and also long COVID patients in order for us to be researched. We don't have the time to ponder the first when we still aren't included in the many. There are still no studies that place an emphasis on the physical, financial, mental, and social experiences of Black people living with long COVID. And if there are no studies that effectively investigate us, there is no way of detecting how this impacts our paychecks, disability benefits, families, mental health, neighborhoods, and other entities that have been completely devastated by COVID-19. And if we don't know or feel this impact in Black and urban communities who are already at a disadvantage, a community that I live in, then who are we speaking to when we make decisions about treating and managing long COVID? It is imperative that I am one of the first to be researched in studies about long COVID, especially neurological studies. As a Black teacher in Baltimore City, I know that I am a hot commodity in education. It's been proven that Black students who are taught by Black teachers are more successful. They become a part of many of the first. I would rather be right now, instead of talking to you, I would rather be in a classroom wrapped in all of the PPE in the world, teaching my young middle schoolers, and instead of being the first Black woman or one of the first Black women to talk about long COVID. But long COVID has destroyed my brain. It makes it impossible for me to teach anybody how to do anything. I couldn't even teach a dog how to bark if I tried. After this, I won't remember what I said. My head feels like a throbbing bowling ball every single day of my life. I don't want my experience to continue happening to the many Black people I represent. Black people still operate as villages. So when we are the first to know and do something, we know that we can create the many to know and do the same. I have been rejected now 3 times from an important NIH neurological study. And after talking to some other Black people, I am realizing that I am not the first to be rejected as a participant. This is irresponsible of researchers. It is dangerous for us, as my beloved students would say, to play the 50, to pretend we don't see what we know we do. I may not make friends challenging well-known doctors to consider Black people's place in research, but those are the risks in being first, and I will not stop trying. Fighting to save my own life last year has made me annoyingly fearless. If my burning brain, memory, and vision loss after March 20, 2020 isn't enough to be a part of long COVID research, I don't know what is. Alas, I am learning, though, that if I can't walk through the doors of anything, I can break windows. And if that means I use being Black and first to help create safe, meaningful, and relevant research spaces for Black people and urban communities, I will proudly gather my cuts and my bruises to continue to admonish that long COVID studies incorporate Black patients so that I will be the first of many. Thank you.
Yeah, thank you. That was incredibly powerful. It breaks my heart that you have been put into this position. All I can say is from our perspective, we're working to address that. I know we are thinking about a study, in using our registry that examines really what's going on in people of color. I know that's a small amount of what should actually be happening. But please continue to do what you're doing and to advocate. I know it's not easy for you, especially given the physical manifestations that you're having from long COVID. But thank you for those powerful words and for everything that you're doing. It really means a lot.
Thank you.
Okay, next up we have Lisa McCorkle, who is the team lead of Patient-Led Research Collaborative, which is a group of citizen scientists with long COVID. Lisa has a master's in public policy from UC Berkeley, lives in Oakland, California, and works as a policy analyst at the California Department of Social Services. Lisa, Shamir's a hard act to follow, but I'm confident that you can do it. So please take it away, and we're excited to hear about the work that you've been doing.
Thank you so much. And yes, I agree. Shamir's a very hard act to follow. Thank you so much to Solve ME for hosting me and this whole advocacy week, and to Representative BEYER and to Shamir for sharing before me. And Shamir, I just wanted to mention, I know you said you can't teach right now, but I, for one, have learned so much from you, and I know that everyone else on this call has as well. So I really appreciate you and appreciate being able to work alongside you. So today I'm going to talk with all of you about Patient-Led Research Collaborative, who we are, our work, the benefits and challenges to patient-led research, and some tips for what you can be looking for if you want to be part of a research study. So first off, who are we? Who is Patient-Led Research Collaborative? We are a group of long COVID patients who formed out of Body Politics COVID-19 support group on Slack back in April of 2020. So we actually just celebrated our 1-year anniversary. And most of us got COVID in March of last year. We were also kind of the first of our friends. And we all joined the support group after not recovering from our initially mild cases of COVID. In the Slack support group, we saw that there was just this wealth of information being shared on patients' symptoms, different treatments they were trying, of the progression of their illness, of doctors and loved ones not believing them, and a group of us who had backgrounds in various areas of research, whether it be policy like me, participatory design, neuroscience, data collection. We created a survey to aggregate all of this information, all of this data. And after receiving 640 responses, and after only 9 days of analysis, we produced the first report on long COVID. So the first report is on the screen now. In this report, we documented a lot of symptoms that were outside of the list that the WHO and CDC were listing as symptoms from COVID, particularly many neurological symptoms. And we also proved with this survey that there was a pretty big subset of COVID patients who are experiencing these prolonged symptoms. A lot of patients who had previously felt completely isolated and gaslit felt like this report validated their experience. And it led to us being connected to many ME/CFS groups. And it also helped to start the conversation about long COVID by being featured in articles like The Atlantic and in several medical journals. Next slide, please. Thank you. But we realized that our first survey was not enough. As we ourselves continued to experience symptoms, so did our community. And we were able to get IRB approval through University College London, since one of our team leads, Athena, is a neuroscientist there. And this was a bit of a trade-off because our first report, we were able to get results out super quickly, largely because we did not have to go through that regular research process of getting IRB approval, of dealing with getting formally published. But we wanted to make sure that our community and our research would be taken seriously by other researchers, by doctors, and by policymakers. So we put together this second survey. We offered it in 9 different languages. It was very long. On average, it took about 70 minutes to complete, which is a long survey for anyone, much less folks who are experiencing brain fog and post-exertional malaise. And so knowing that, we chose our questions very methodically based off what we were hearing mattered to patients, what we were experiencing ourselves, and what we were hearing from patients with similar illnesses like ME. And we didn't collect data just for data collection's sake. We inserted breaks throughout the survey to remind respondents to stop, rest, and pace, which is something we thankfully learned from people with ME. And patients could come back and finish the survey at a later time if they wanted to take a break. So with this survey, we received over 6,500 respondents from 86 countries, and we issued a preprint. You can see that on the next slide. We issued this preprint in December of 2020, And this was an analysis on a subset of our respondents. And it was really important to us and our community to include both confirmed and suspected COVID cases. I'll put a link to our preprint in the chat afterwards, so you can all kind of take a deeper look at our findings. But I know you're tired of hearing it, and this is the title of the slide on the screen, but these really are some unprecedented times, and that is especially the case for patient-led research. Between 10 to 30% of people who get COVID will develop long COVID, and this really is a mass disabling event. And during times like these, people want answers quickly. And so in the absence of similar traditional medical-led research, our research, which was done quickly, became a key source of information for public officials and medical professionals. And because of the groundwork that was laid by HIV, MECFS, and many other activists, we had the historical knowledge, the patient platform, and the perfect kind of window of opportunity to have immense impact. Some of the examples of our impact and involvement is listed on the screen, and much of this has been done in partnership with Body Politic and other long COVID and MECFS advocacy organizations. Some of my favorite highlights were in the top 0.1% of medRxiv preprints, which is pretty cool. We've informed guidance for multiple government agencies, and we've been consultants on future and current long COVID research studies. So I wanted to touch on some of the benefits and challenges of doing patient-led research, because there's several of both. On the benefit side, we've learned that this kind of research lets us ask the right questions because we have a very intimate understanding of the illness and of our community. The value that patients bring to research truly cannot be overemphasized. It really is critical. Not only do we ask the right questions, but we ask them earlier, and we can get them answered earlier than a lot of traditional research is able to do. And within our group, within Patient-Led Research Collaborative, we each have different backgrounds and skills. We all have a different lens we bring, which makes us really effective and also very holistic. We're not all just the same kind of doctor looking at a problem. And our motivation is our health and the health of our community. We don't have any secret ulterior motives that could get in the way of making decisions that are good for our community. But there are a lot of challenges that we faced as well. The research takes a lot of effort, and we're all living with ongoing disability. In fact, one of my worst crashes was after working too long on some long COVID advocacy work. But that's led us to establishing ground rules within our group where we prioritize our health over all else, and we ensure that we are using our spoons wisely. Another challenge that we've come across is a lack of resources, access to medical system records, diagnostic testing, labs, large population groups, and that really limits the type of research that we can do and questions we can answer on our own. And that also leads to methodological challenges. We cannot do something like a randomized control trial. And as patients, we do have inherent biases that could impact the research that we do. So that's something to keep in mind as well. In regards to funding, we have some donations, and our donations have mainly been funding our website and other operating costs. But so far, we haven't had funding to provide incentives to all survey respondents, which we would love to do, or to pay ourselves for our labor. Though hopefully it's looking like that may change soon, and we'll be able to sustain our work for longer. Developing some sort of organizational and governance structure has also proved to be a bit challenging, given that we started out just a year ago and we're complete strangers on the internet, just a bunch of strangers from across the world. Pretty incredible that we were able to work so well together, but there's been some challenges with that as well. And of course, because we're outside the normal research system, we'll always have some doubters and some trolls on Twitter who call our research Mickey Mouse science. But we like to say we've reclaimed that, and we are now proud Mickey Mouse scientists. Next slide, please. But with all that being said, I want to emphasize that the most important thing that I've learned over the last year is how critical patient involvement is in research, and that there are many traditional researchers out there who really do value our involvement. but we as patients need to help drive the agenda and be part of research in order for work to be done that will actually help us. So if you're looking to be more involved in research, I cannot recommend that you do so either by doing your own, if you're able, advising on other research, or participating in more studies. And I want to expand on that last point a bit more, because that's really what's probably the most accessible thing to most of us. So there are some key questions to ask of researchers and answers to look for to ensure that the research is being done well and that patients are going to get out of it as much, if not more, than what they put in. Not all of these have to be perfect, but they are things to consider before joining a study. So first, what do researchers do with your data, and are you going to see the results? If it's important to you to have your data protected, knowing who is going to own that data and who it's going to be shared with are really important to know. This also includes if you're going to see the results of the study and of any blood tests or invasive tests that are done on you. Will your own data even be shared with you? Secondly, what research questions are they trying to answer? And do these questions even matter to your community? That should definitely be the case. Who was consulted on the study? Were any patients consulted? Studies should really be transparent on whether and how patients have been involved. And if they are, that can help you see if patients are being valued by the researcher. Is this research building on prior research? We should really be building on prior validated work, not acting like we're starting from scratch. Who funded the research? Do they have any stake in the outcome of it? It's important to be aligned with the values of the researchers and the funders of the studies you're participating in, so that you know that the outcome will be an accurate representation of the data. If it's a survey, how long is it going to take? How easy is it to take? How much energy will it require from you? Will you be compensated? These are different for every patient, and maybe the research question is important enough that you're willing to not be compensated and spend a lot of energy on it, like many did for our survey. But it's important to take stock of that prior to committing to being part of the study. Are researchers intentionally trying to be inclusive of racially or ethnically marginalized populations, of those who live far from health clinics, of people who are normally not included in research? If not, in all likelihood, the study is not going to be representative. And so who this research helps is going to be very limited. And are any of the researchers themselves people of color? Are they disabled or from a marginalized community? Or were these communities involved in developing the study? Representation matters, as Shamir pointed out, and who is performing the research and their cultural competence can make or break an experience in a study. So that's my time. Thank you so much for listening. You can see more from us on our website at patientledresearch.com, or we're on Twitter at patientled. A little plug that we have a survey out now for anyone who has had at least one dose of a vaccine. We'd love for you to take our survey. You do not need to have had COVID. The link is on the screen. And lastly, I know many folks on the call may have a chronic illness or have a loved one who does, many of you long prior to COVID. And a lot of you sounded the alarm for this impending wave of disability from COVID and were not listened to. But your guidance to PACE, your welcoming arms, and your support have made all the difference for us this last year. And we would have not accomplished the progress we have made without your decades of advocacy. So thank you all.
Thank you so much, Lisa. That was fascinating. And, you know, we should talk about your vaccine study. We've just embedded one into our registry. So I'd love to share findings and see if we can look at those data sets together and better understand how that's impacting individuals. I would just like to also say thank you. When we were building our registry for the long COVID, long haulers population, one of the first places we started with was the surveys that you guys had built. And rather than doing something different, we used what you'd done as a blueprint and really built our data collection from there. So the work that you did has truly influenced us for sure, and I'm sure lots of others. So thank you.
Thank you so much.
Okay, we're going to transition now to Shannon Van Velden, who is the director of the Rare Disease Legislative Advocates, which is part of the Everyday Life Foundation for Rare Diseases. Shannon works with rare disease advocates across the country to engage on the local, state, and federal level. She began her career on Capitol Hill as a legislative assistant for Congresswoman Shelley Berkeley from Nevada, working on healthcare and veterans affairs issues. Shannon has worked with the national non-profit organizations to further their policy and advocacy goals, including the Juvenile Diabetes Research Foundation and the National Osteoporosis Foundation. Shannon received her Master's of Public Policy from American University. So we're delighted to have Shannon join us today and excited to hear what she's got to say. Over to you, Shannon.
Thank you so much, Sadie and Ovid, and also to Emily and Jessica, who have been so wonderful partners to the Every Life Foundation. I'm excited to be here today. I work with the Every Life Foundation. We're a nonprofit, nonpartisan policy organization located here in Washington, D.C. And we're dedicated to empowering the rare disease community to advocate for science-driven legislation and policy that advances the equitable development of and access to life-saving treatments. And I'm excited today to share a little bit about the National Economic Burden of Rare Diseases study. This was commissioned by the Every Life Foundation over the last year, and the study results were released this past February. And at the heart of this study really was the patient community. The patient community has been involved in this study from its inception. It was conceived of by our Community Congress Working Group, which is joined by patient organizations from across the country. Patients have been involved in the study design, the technical advisory board, survey design, survey dissemination, and processing the findings. So this truly was a study by the community for the community, and we're continuing to work with patients as a result of the study. Impacts on decision-making and policy solutions. So one of the main reasons why we set out to do this study was because there was so much variability in what we thought we knew about rare diseases, such as the number of rare diseases and the number of people with rare diseases. Researchers estimate that there are more than 7,000 rare diseases and that they affect an estimated 30 million Americans, but really we're lacking that scientific and peer-reviewed literature to support these estimates. Next slide, thank you. So we set out, this quote really highlights that we don't have the data to make good decisions in the current healthcare ecosystem for rare diseases without good data. And this is the problem that the study is trying to address. One of the reasons why this is so important to the community is the cost of diseases is used in critical decision-making, including those by payers, which are insurance companies that are looking at the direct cost of the rare diseases. And not all the costs that patients and families know are attributed to living with a rare disease, such as caregiving is one prime example of that. So with the study, we're trying to move from those back of the envelope calculations to high quality data to inform the decision-making all across the therapy development ecosystem. So the cost estimates then are used to prioritize policy agendas and understand the impact of diseases or groups of diseases to enable us to determine what those public health priorities should be. So the study purpose, we conducted the largest, most comprehensive assessment to date, and moving from those anecdotal cost estimates that we hear from patients about the cost of living with a rare disease to that high quality evidence that we've been lacking. The study was really unique that we weren't just looking at the direct medical costs, which would be prescription drug costs, doctor's visits, and so forth, but also those indirect costs and non-medical costs that usually are absorbed by the patients and families themselves. And the research was led by the community for the community and represented hundreds of rare diseases. We're looking to fill that knowledge gap regarding those less examined costs. So the costs that are absorbed by the individuals, caregivers, and families, and also knowing that there's such an impact on one's ability to contribute in the workplace and community as well, which has costs. So really the three main takeaways was evaluating the economic impact of living with a rare disease on individuals and families and the public, informing policy to better align the investment into rare diseases to reflect the public health urgency, and then working together to advocate for policy changes to improve the lives of patients and families. So the results of this study that we released in a report in February showed that the total economic burden of the 379 rare diseases that were included in the study was nearly $1 trillion in the year of 2019. So we were calculating those costs prior to COVID and the pandemic. And the study only in court was for one set year. So families who participated in the survey, for instance, maybe they had done a huge home modification in 2018, that would not be included in 2019. So obviously there are some limits to the way this, the 1 year of the study. But the study assessed the 379 diseases out of over 7,000 rare diseases. So the estimated prevalence is about 15.5 million people. So this is a very conservative estimate of costs, since we know that there are so many more rare diseases and so many more people living with a rare disease, that the cost is much higher in actuality. And so one of the really unique pieces of the study was looking at those costs beyond the direct medical costs. And what you can see here is that the direct medical cost is not the highest cost facing those living with a rare disease. It says indirect costs, which include productivity loss and forced retirement. This was actually a term that the patient community that we were working with, I think we were saying workplace loss, and they were like, well, we haven't really, it's the fact that we've been forced into retirement because we're unable to work due to our condition. That was really, was very helpful in us telling the story of what this study meant. And then also those non-medical and uncovered costs, which are traveling to doctor's appointments or procedures, which can be all over the country, education costs, those home and auto modifications, were really the drivers of the costs for patients, their families, and also our public health system. And it was also really important to us while we were doing this study. The study included a survey that the patient community helped us develop and then also disseminate through various patient organizations throughout the country. And it was really important for us to include some of this non-economic information that we thought was really valuable in order to better understand all the different experiences that are related to living with a rare disease. And one of those is the diagnostic odyssey. So as part of this survey of 1,600 patients, caregivers, and family members who filled out the survey, we wanted to make sure to include these additional questions. And when we asked about the diagnostic odyssey to better understand it, we learned that the diagnostic odyssey took over 6 years and included 17 medical specialists in order to find that diagnosis. And when you think about over 6 years and 17 medical specialists, that means a really high cost as well. That includes travel, childcare expenses, invasive testing, missed work, and school, most certainly. So there's a whole host of costs related to this diagnostic odyssey that so many rare disease patients are faced with. And so based on this data, it really represents this urgent public health crisis that so many within the rare disease community have known about for so long, that finally puts those numbers out to be able to put a real taste of what so many of us already knew. And the public health crisis demands most certainly increased funding for research, enhanced awareness and resources to improve access to timely diagnosis, care, and treatment. And I'll just finish out with some words from our board chair, Mark Dant. He's also the father of an adult son with a rare disease, who has the most amazing story. But the national economic burden of rare disease study is a defining moment in a decades-long effort to overcome the challenges of rare diseases. This new economic evidence can guide policy decisions with real and lasting benefits for families and society. We must act on it. Thank you so much for having me. And I just want to thank too, like all of you and the patient organizations and patients who participate in this study. We're looking forward to continuing to work with the patient community to get the word out about this study.
Thank you so much, Shannon. And I think we all know that the data is what moves the needle, right? You can tell someone that, you know, something has an impact, but until you show them the data, that's when the people really start to listen. So thank you for the work that you've done to provide that body of evidence. Seems really comprehensive, and hopefully it will help in the rare disease space. So we have about 5 minutes left, and I do have a question for each of you. If you can limit your answers maybe to about 1.5 minutes or so, that would be awesome, so we can try and finish on time. I'll start with Shamir. So obviously there are growing reports of challenges faced by many of the national post-COVID clinics, including long wait lists. How might community leaders help to provide more strategic care to long COVID patients in urban communities?
Thank you for asking that. Community leaders can get very creative by instituting and using some of those, especially in urban communities, using some of those buildings that house like recreational centers. Although we're still in the process of vaccinating, some long haulers can actually come to community centers and recreational centers to be studied and to have people, you know, capture their data and their research. So we just need to use the places and the buildings that we have. Long COVID clinics are not the only places in urban communities to serve those communities. We can use our centers, and we can take very quick studies to capture data so that we can report those findings back to hospitals like Hopkins and the NIH and the CDC for true data.
Yeah, I think that's a great idea. We've seen in the ME/CFS community that, you know, we have these satellite clinics spread around the country, and if you don't live near them, you're out of luck.
Yeah.
So really adopting some of the learnings that we've found during the acute phase of the pandemic, telemedicine, using unusual places to identify and treat people. I think that's a great idea.
Right, I agree. Thanks.
Okay, so next question to Lisa. So you touched briefly on how people can be more involved in research, either by doing their own research or advising. Can you explain a little bit more about how people might be able to do that or to get involved in research in other ways?
Yeah, absolutely. So like I said before, I think we as Patient-Led Research Collaborative and long COVID patients, we're in a really unique position, kind of the perfect time and place or like Zoom room, I guess, for our research to be listened to and have the impact that we did. But I think really any patient, as long as they have the support of their community, can do research on questions that matter to them. If they're not already a medical researcher, they could face a lot of the barriers that we face, but getting those questions answered as best they can is still doable. It's just getting kind of the right people with the right skills to help you along the way. And there are a lot of projects being worked on right now that'll make it easier to connect patients to researchers. The Solve ME's You and Me registry is definitely one of them. Another one that we're helping out with is called Hugo, and that should be out fairly soon. So be on the lookout for opportunities like that. And in terms of advising, I'm really hopeful that patient advisory committees are going to be the standard from here on out. They already exist for a lot of folks, and hopefully that'll just keep growing. So I encourage patients who are interested to look up any patient advisory committees on studies that they see, or ask funders, particularly if they'll include a patient oversight or engagement group in their call for proposals. That's something that we saw with the NIH and their recent research opportunity announcement for long COVID, is we saw a patient engagement working group in the proposal itself. So advocating for more patient involvement among funders and researchers, and then actually being part of those committees are some of the best things I think patients can do to get involved.
Yeah, I agree. I mean, I think the other thing is just to realize the power of your voice and the power of your data, right? It's incredibly powerful. I think there's been a realization of that, certainly over the past year, if not a little before that. But, you know, it's really, to me, reached some kind of momentum where that expertise and that data is really being valued, and the patient voice is being sought out. So I think grab it if you know, realize how valuable it is, and grab it. Okay, and then finally, question for Shannon. So the study that you did is the first of its kind that really put on paper what many families and patients already knew about the cost of having a rare disease. Why do you think it's important to advocates, and how can the data be used to change policies?
I mean, I think that the data is such a critical tool for advocacy, having those numbers and backing up those personal stories that patients have been telling for years. When that $966 billion in a year number gets communicated to the Hill and policymakers and payers, that becomes a huge elephant in the room that must be addressed. And it really puts to the forefront that this is a public health crisis that decision makers need to address in order to ensure that we're able to not go bankrupt with rare diseases or any other. The Alzheimer's community had a similar study many years ago that was brought to the Hill that really highlighted the cost of Alzheimer's, and the Hill really set into action to solve the problems regarding research and increased awareness and resources for the community. And so it just highlights really the impact that that data can have for decision makers.
Yeah, I agree. I think it's incredibly powerful. I agree. So I know we're a couple minutes over, but I just wanted to take a minute to thank all of our panelists today, Shannon, Lisa, and Shamir. Your input has been incredibly powerful and interesting and helpful, and hopefully people on the call today have enjoyed it as much as I have. So the next thing we have coming up as part of Advocacy Week is the EmPOWER M.E office hours. You see them listed here. So at 10 a.m. Pacific, 1 p.m. Eastern, we have Shamir and Lisa. At 12:30 Pacific, 3:30 Eastern, you have Ovid and I, and you see the link there to join the Zoom meeting. So we hope to see many of you tomorrow, and thanks to everybody for listening in today.
Thank you so much, everyone. That concludes our presentation of the 3rd Annual EmPOWER M.E Roundtable. Don't forget, we continue tomorrow with additional office hours for the opportunity to have one-on-one connection with our panelists and each other. There's no registration necessary for the panels tomorrow, so feel free to join at either 10 a.m. Pacific or 1 p.m. Eastern time, or 12:30 p.m. Pacific and 3 p.m. Eastern time. Both of these office hour events last about an hour, so that's about, you can come and go at any time you please. There's no need to stay for the whole time. And again, there's no registration necessary. Just click that link during any of the hour windows for the office hour sessions, and you'll be immediately brought into the conversation. Thank you all so much once again. For more information about the rest of MECFS Advocacy Week, feel free to visit us at www.meadvocacyweek.com. This has been a presentation of the Solve MECFS Initiative, solveme.org, and the Long COVID Alliance, longcovidalliance.org. Thank you so much for joining us today.